Hello, everyone. Thank you for joining this webinar on the basics of Factor 13 deficiency. I hope everyone is staying safe and healthy during these unprecedented times. I would like to thank NHF for this opportunity and Chelsea and Jasmine for organizing this session and for all their hard work in recording this session today. I'm Suchitra Acharya, a pediatric hematologist at the Cohen Children's Medical Center in New York. And over the next 30 minutes or so, I will go through the basics of Factor 13 deficiency, including the role of Factor 13 in the clotting cascade, signs and symptoms of Factor 13 deficiency, diagnostics, testing, treatment strategies, as well as touch upon girls and women with Factor 13 deficiency. Here are my disclosures, none of which are relevant to today's presentation. I would like to share this visual with you, which has actually been designed by doctors Usha Reddy and Dr. Roshni Kulkarni. And this really gives you a good visual on how blood actually clots in our body. So this is a blood vessel, which is lined by endothelial cells. And you have the cellular component, which include red cells, white cells, and platelets. And the liquid component of blood, which we refer to as plasma, which contains clotting proteins, which help you form a clot, which prevent clots, as well as help in clot breakdown. So whenever there's tissue injury, either from trauma or a surgical procedure, there's a breach in the continuity of the blood vessel. And platelets are the first cells to go to this site of injury, and platelets stick to the lining of the blood vessel, the endothelial cells, referred to as platelet adhesion. And platelets also stick to each other in a process called platelet aggregation, in an effort to form a platelet plug, which is the first important critical step in the blood clotting process. As platelets are being recruited to form the platelet plug, clotting proteins in the blood, which are labeled from 1 to 13 as part of the extrinsic, intrinsic, and common pathways, form a clot, which is referred to as the fibrin clot. And soon after the fibrin clot is formed, as you can see in this diagram, Factor 13 comes into play to cross-link the fibers of the fibrin clot, the fibrin monomers and polymers, in order to form a tensile clot. And finally, there is resolution when the healing process begins and the blood vessel returns to normal. So what do we know about Factor 13 deficiency and its prevalence? Factor 13 is considered a rare bleeding disorder, and rare bleeding disorders comprise 3 to 5% of inherited bleeding disorders after von Willebrand's disease and hemophilias, which are more common. Factor 7 deficiency is the most common of the rare bleeding disorders, and Factor 13 deficiency is one of the rarest of the rare bleeding disorders, with the prevalence in the Western world reported as around 6.5%. Factor 13 deficiency is inherited in an autosomal recessive manner, which means that both parents need to be carriers in order for the child to manifest the bleeding disorder. As you can see in this pedigree, you have a boy and a girl who are severely affected. And there's one boy who is a carrier and a girl at the bottom rung of the pedigree who's unaffected. And as you can see, both the parents are carriers. And when both parents are carriers, there's a 25% risk with every pregnancy that will produce an affected child with the bleeding disorder. Our understanding of rare bleeding disorders and its prevalence has vastly improved because of registries that have been maintained in the United Kingdom, Italy, and Iran for a few decades now. As you can see on this slide, if you look at the prevalence of the hemophilias, Factor 8 and Factor 9 deficiencies, they are similar in prevalence in all the three registries. However, when you look at the prevalence of factor 13 deficiency, it's 3 to 5 fold higher in the Iranian registry as compared to the Italian and UK registry. And why is that? One of the reasons cited for this increased prevalence of rare bleeding disorders such as factor 13 deficiency in the Middle East and Southeast Asia is a high rate of consanguinity, which is offsprings born of first cousin marriages or uncle-niece marriages. And the rate of consanguinity reported is from 40 to 85%, which is in a state in southern India. And this translates into a 3 to 7 fold higher prevalence of factor 13 deficiency and other rare bleeding disorders in the Middle East and Southeast Asia as compared to the Western world. World Federation of Hemophilia report published in 2012 reported equal gender distribution for factor 13 deficiency, as you can see in this slide, amongst males and females, unlike the hemophilias seen in the two upper bars, which are predominantly prevalent in males because of the X-linked recessive inheritance, whereas with autosomal recessive inheritance, which it can occur in both males as well as females. So what is the role of factor 13 in the clotting cascade? Factor 13 is also known as fibrin stabilizing factor, and it's important to prevent clot breakdown. As you can see on this slide, the lower panel, you're seeing normal cross-linked clot, which with a very tight network of fibrin monomers and polymers. On the other hand, the upper panel shows you a non-tensile clot in somebody with factor 13 deficiency, where there's a loose network of these fibrin monomers and polymers. And this is easily susceptible to clot breakdown. So one of the roles of factor 13 is to resist clot breakdown. Factor 13 also is important in the wound healing process, and it's important in maintaining pregnancy because factor 13 is required for implantation of the fertilized embryo into the uterus soon after conception. So factor 13 deficiency occurs in 1 in 3 million individuals. As mentioned earlier, it's very common with consanguinity. Individuals present with a lifelong bleeding tendency, which can begin at birth as persistent umbilical cord bleeding, as shown in this upper panel, and can also present as an intracranial bleeding, brain bleeding during the delivery process. Otherwise, more common symptoms include bleeding into the skin and lining areas, referred to as mucocutaneous bleeding. Joint and muscle bleeds, which are more common in the hemophilias, are relatively rare with factor 13 deficiency. The bleeding pattern in factor 13 deficiency after trauma and surgery includes delayed bleeding, which means that, say, trauma occurs today, the patient may report bleeding 3 to 4 days later. Similarly, after a surgical procedure, if you have a surgical procedure today, 3 or 4 days later, patient may notice opening up of the wound, which we refer to as wound dehiscence, because there's impaired wound healing because of lack of cross-linking of the fibrin clot fibers. There's also inadequate scar formation. And in women with severe factor 13 deficiency, in the absence of replacement, there's repeated spontaneous miscarriages. Factor 13 circulates as a tetramer, which means it's a combination of two subunits of proteins. Subunit A, which is the active subunit, has the enzymatic activity, and subunit B, which lacks enzymatic activity and acts as a carrier molecule for subunit A. And you can basically inherit either subunit A, B, or A and B deficiencies. Subunit A deficiency tends to be the most common and can present with severe bleeding because it is the more active component. And subunit B is less common. It's rarer than subunit A deficiency and also less severe in terms of the bleeding symptoms. And a combined deficiency of subunits A and B are extremely rare. So typically when you evaluate an individual for a significant bleeding event, we run a battery of tests called a bleeding screen, which includes a complete blood count, which gives us an idea about the platelet count, the platelet numbers, as shown earlier. You can have bleeding symptoms if you have low numbers of platelets, or the platelets do not function normally. The prothrombin time of PT screens for clotting factors 2, 5, 7, and 10, and the partial thromboplastin time of PTT screens for factors 8, 9, 11, and 12. All these screening tests are normal in an individual with factor 13 deficiency, because factor 13, the role of factor 13 is after clot formation, and these screening tests screen for deficiencies as the clot is formed and the different components involved in clot formation. So in order to diagnose factor 13 deficiency, you need to do a factor 13 antigen level, which is the quantitative assessment of factor 13. That is the amount of the factor 13 protein that's made, and a factor 13 activity, which tells you the function of the factor 13 protein. In the past, we used to use a screening test called the 5-molar urea clot lysis test, which has very poor sensitivity. That means it's usually normal above levels of 2 to 3%. And so you will only diagnose the very severe factor 13 deficiencies and miss out on the moderate and mild factor 13 deficiencies, which are important to diagnose so that bleeds and prophylaxis and other treatment strategies can be appropriately implemented. So classification of factor 13 involves work that was conducted by Dr. Flora Paivandi and a group from Milan, Italy, who established the European network of rare bleeding disorders, and which was further expanded as an international project on rare bleeding disorders. And based on the data that Dr. Paivandi and her group analyzed, they proposed a classification for factor 13 deficiency as mild factor 13, where levels are more than 30%. Moderate includes levels less than 30%, and with severe deficiency, factor 13 levels are undetectable. In general, factor 13 activity levels do correlate with bleeding symptoms, and most individuals with levels less than 30% do have a tendency to bleed. However, spontaneous bleeding typically does not occur unless and until your levels are less than 15%, and those individuals with levels less than 5% have a severe bleeding tendency. Treatment strategies for factor 13 deficiency include replacement therapy, prophylaxis, and the use of clot strengthening agents or anti-fibrinolytic agents. Replacement therapy involves the type of factor 13 deficiency and the severity of the deficiency, the type of bleed and location of the bleed, and replacement is usually continued until healing is complete. Prophylaxis is one of the strategies in factor 13 deficiency that works, which I will be discussing in a few slides, and involves replacement of factor 13 after an intracranial bleed or recurrent joint bleeds during pregnancy and prior to dental and surgical procedures. Anti-fibrinolytic agents are clot strengthening agents used when there are bleeds or surgical procedures that involve lining areas in the body, because lining areas such as bleeds in the mouth, the nose, the GI tract, uterus in females have an abundance of clot breakdown enzymes. And so using a factor concentrate along with these clot strengthening agents would help control the bleeding and preventing bleeding during a surgical procedure much better. Factor 13 products that are currently available are factor 13 concentrates, which really should be the preferred treatment and the mainstay of treatment for an individual with factor 13 deficiency in 2020. There are two concentrates that are available: a plasma-derived concentrate that contains both your subunit A and B deficiency and can be used in any patient with factor 13 deficiency. A recombinant product is available for individuals who have only subunit A deficiency. The advantages of using concentrates is number one, they're virally inactivated, and the volume of infusion is smaller, and so it's easier to administer. If for some reason a factor 13 concentrate is not available, the next option would be fresh frozen plasma or cryoprecipitate. The disadvantages of these products is that they are not virally inactivated and there's a higher risk of transmission of blood-borne pathogens. Also, large volumes are required to be infused given the low concentration of factor 13 in these products, and sometimes patients can develop severe allergic reactions. Dosing with factor 13 concentrate should be based on measuring trough levels, aiming for levels between 5 and 20%, and based on the levels, you could increase or decrease the dose to target these levels. Also depends upon the timing since the last dose, and depending upon if the last dose was a week prior or 3 to 4 weeks prior, there is room to either not use an additional dose, use a partial dose or a full dose, again aiming for levels of a minimum of 5%. So long-term prophylaxis for factor 13 deficiencies, it works, it's essential, because one of the life-threatening bleeds that occur with factor 13 deficiency is an intracranial bleed, and therefore I think it's important to implement long-term prophylaxis once an individual is diagnosed with factor 13 deficiency. It's one of the few rare bleeding disorders where it's highly recommended that individuals with factor 13 deficiency do undergo long-term prophylaxis. And the reason it works and is doable is because factor 13 has a long half-life, up to 2 weeks, and levels as low as 5% are usually adequate to prevent severe bleeding. So these are really, advantages, and because it is a long half-life, the frequency of administration of factor 13 products is every 4 to 6 weeks, precluding the use of a central line, which sometimes may be required when you have products with a shorter half-life requiring more frequent administration. So the preferred treatment, as mentioned earlier, is a factor 13 concentrate every 4 to 6 weeks based on the trough levels, aiming for trough levels anywhere between 5 and 20%. And if factor 13 concentrates are not available, plasma can also be used every 4 to 6 weeks, again, tailoring to the trough levels. Primary prophylaxis is the use of preventative treatment before the occurrence of a bleeding event, and it is highly recommended in patients with severe factor 13 deficiency in order to prevent life-threatening and devastating bleeds such as an intracranial bleed. Girls and women with factor 13 deficiency have a lifetime risk of bleeding during their periods, during pregnancy, and during delivery. Heavy menstrual bleeding has been reported in up to a quarter of girls and women with severe factor 13 deficiencies, and miscarriages have been reported in up to 60%. Apart from these, girls and women can also bleed at mid-cycle during ovulation, associated with the rupture of the corpus luteum, and sometimes this can present as severe abdominal pain because of hemoperitoneum, blood that is in the lining of the abdomen, which could be life-threatening and is a medical emergency and needs to be addressed right away. Also, very high rates of postpartum bleeding have been reported in women with severe factor 13 deficiency. What are the consequences of heavy menstrual bleeding? Anemia from severe iron deficiency can cause impairment of higher brain functions such as focus, concentration, and so really needs to be addressed in a timely manner. Apart from severe anemia, limitations in daily activities, a reduced quality of life, time lost from work and school, and adverse psychosocial effects can also occur in girls and women because of heavy menstrual bleeding. And that is why it's really important to look for causes of heavy menstrual bleeding, get to the bottom of it and treat them appropriately. Management of heavy menstrual bleeding includes whether a pregnancy is being considered soon or not. If a pregnancy is being considered soon, the treatment of choice would be factor 13 concentrate treatment along with tranexamic acid and aminocaproic acid, which are the anti-fibrinolytic or clot strengthening agents. If there is no pregnancy on the horizon being considered, hormonal therapy plays an important role in controlling heavy menstrual bleeding in the form of levonorgestrel or the Mirena IUD, a combined oral contraceptive pill, or a progesterone-only pill. If a woman has decided that she's completed having her childbearing and has completed reproduction, endometrial ablation and hysterectomy may be options to consider. A woman who's pregnant with factor 13 deficiency, who herself has factor 13 deficiency and has a risk of having a child with factor 13 deficiency, needs to be cared for at a bleeding disorder center or a hemophilia treatment center, and requires a multidisciplinary approach with collaboration between the obstetrician, hematologist, anesthesiologist, primary care physician, along with lab support for monitoring of levels that are required during pregnancy and after delivery. Replacement therapy needs to start in the first trimester soon after conception, because factor 13 is required for implantation of the fertilized embryo. Epidural anesthesia can be used as long as factor 13 levels are maintained above 50% when the catheter is being placed, as well as 24 hours after it's removed. The route of delivery, vaginal versus C-section, should be chosen that is safe for both mother and child. The risk of postpartum bleeding, PPH, or postpartum hemorrhage should be strongly considered and discussed with the woman with factor 13 deficiency, as well as late postpartum hemorrhage, which can occur 2 weeks after delivery, should also be discussed. A baseline CBC before discharge should be obtained so that you know where you're starting from in case there's excessive bleeding as part of late postpartum hemorrhage. There's a very high risk of miscarriage, as mentioned earlier, without factor 13 replacement. And so soon after a woman knows she has conceived, factor 13 replacement with factor 13 concentrate needs to begin, aiming for levels above 10% in order to prevent obstetrical bleeding. In early gestation, doses of 250 units per week. After 6 months, doses of 500 units per week, and at the onset of labor, a bolus of 1,000 units of a factor 13 concentrate is recommended in order to carry a pregnancy through and also for a safe delivery. A suspected newborn with factor 13 deficiencies where both parents are known to be carriers for factor 13 deficiency should be again managed through a multidisciplinary approach, as mentioned earlier. Vaginal delivery is feasible, but if the second stage of labor is prolonged, avoid forceps, vacuum, fetal scalp monitoring, which can actually trigger an intracranial bleed in the newborn. If the second stage of labor is prolonged, I think C-section is recommended right away. After the baby is born, cord blood can be tested for factor 13 level if it's feasible, and a screening head ultrasound needs to be done to rule out an intracranial bleed. Intracranial bleeding can also occur up to 7 days, and so the mother needs to be educated to report symptoms and signs of the same, which include vomiting, lethargy, and seizures. Vitamin K and Hep B vaccine should be administered to the newborn. However, in general, intramuscular injections should be avoided in order to prevent muscle bleeds. Immunizations are recommended to be given subcutaneous. The risk of inhibitor development with early factor exposure is not known, and so elective procedures should be avoided in newborns, because obviously any procedure will require replacement with a factor 13 concentrate. And once a baby is diagnosed, if they're not already, getting their care at a hemophilia treatment center or a bleeding disorder center, they need to be referred to one of these federally designated centers in order to have the input that's needed for these patients in terms of prophylaxis, if it's a girl during adolescence, pregnancy, and delivery, in order for individuals with factor 13 deficiencies to lead a healthy and safe life by preventing bleeds and an improved quality of life. Thank you very much for your attention. And if you will take a few minutes now to fill out the session evaluation, it would help us to improve future sessions. Thank you again for being on this webinar.